The following episode is brought to you by the American Urological Association. This special episode comes to you from the AUA Update Series, Volume 43, Lesson 6, AUA Localized Renal Mass Guidelines Update. Led by the AUA Update Series Editorial Committee, the AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology. We hope you enjoy this episode.
AUA Update Series, Volume 43, Lesson 6, AUA Localized Renal Mass Guidelines Update. Authors: Mary E. Hall, M.D., and Peter E. Clark, M.D. Introduction. Since the inception of the initial version of the AUA Guideline on Localized Renal Cancer and Renal Masses in 2009, this series of recommendations for management of renal masses has been an important resource for urologists. As the body of literature on the subject and our understanding of renal cell carcinoma continue to grow, these guidelines have been revised to provide clinicians with the most up-to-date evidence-based recommendations. The most recent version of this guideline was published in 2021, and there are several nuances and changes compared to the 2017 version that are important to recognize and understand. Here, we aim to highlight these updates and provide clinical scenarios which parallel real-world situations in which the guidelines may be utilized. Section 1. Updated recommendations regarding evaluation and diagnosis. Patient Scenario 1. A 42-year-old healthy woman presents to your clinic with a 2.5 centimeter right upper pole renal mass incidentally discovered on CT scan during an emergency department visit for appendicitis. On review of available imaging, this mass was not visible on a CT obtained 6 years ago. Her baseline creatinine is 0.7 milligrams per deciliter, estimated glomerular filtration rate greater than 60 milliliters per minute per 1.73 meters squared. And her only prior abdominal surgery was a laparoscopic appendectomy. After the appropriate diagnostic and staging imaging, including a negative metastatic workup and a thorough discussion of available options, including surveillance, cryoablation, or partial nephrectomy, she elects to proceed with a right robotic partial nephrectomy. Pathology reveals clear cell renal cell carcinoma, PT1A. Postoperatively, you recommend referral to genetic counseling for genetic evaluation. The guidelines section involving evaluation and diagnosis of small renal masses focuses on completeness of preoperative imaging and laboratory studies, with expansion regarding appropriate counseling toward multidisciplinary care and postoperative expectations. As with the previous guideline, the recommended workup includes high-quality, multi-phase cross-sectional abdominal imaging, chest imaging, and comprehensive metabolic panel, complete blood count, and urinalysis. Patients should be assigned a chronic kidney disease stage prior to intervention, and this should be used in counseling the patient regarding their options. When reviewing individualized options for management of that patient's renal mass, consideration should be given to the patient's overall health, comorbidities, and life expectancy, as well as the risks and benefits of each respective treatment option. Over the past several years, increasing importance has been placed on the role of genetic testing for select patients. The key age to remember is that genetic referral should be offered to any patient less than or equal to 46 years of age with a diagnosed renal malignancy. In addition, any patient with multifocal or bilateral renal masses, those with a personal or family history which suggests the possibility of a familial renal syndrome, those with a first or second degree relative with a history of renal malignancy or with a known familial renal genetic syndrome, or those with pathologic findings suggesting a familial renal syndrome, such as fumarate hydratase or succinate dehydrogenase deficiencies, should be referred. Examples of hereditary renal cell carcinoma syndromes include von Hippel-Lindau disease, hereditary papillary renal carcinoma, Birt-Hogg-Dubé syndrome, tuberous sclerosis, and hereditary leiomyomatosis and renal cell carcinoma, among others. Equally, if not more important, is counseling patients about renal function outcomes after intervention for renal masses. Patients diagnosed with renal masses are often elderly and have multiple comorbidities. Extirpative or ablative renal interventions are not benign, and depending on the degree of renal functional loss, may lead to worsening renal function or progression of chronic kidney disease. Referral to nephrology is recommended in patients with pre-existing chronic kidney disease, especially those with estimated glomerular filtration rate less than 45 milliliters per minute per 1.73 meters squared, proteinuria, diabetes, or when a large degree of renal functional loss is anticipated to result in an estimated glomerular filtration rate of less than 30 milliliters per minute per 1.73 meters squared after intervention. Establishing care with a nephrologist prior to intervention is ideal, as this will allow for baseline evaluation by a nephrology provider and potentially lead to more seamless coordination of care in the peri-interventional and post-procedural settings. Section 2. Role of renal mass biopsy. Patient Scenario 2. A 53-year-old man with a history of hypertension presents to your clinic for evaluation of a heterogeneously enhancing, exophytic 3.1 centimeter left lower pole renal mass that was discovered incidentally on CT scan obtained during an emergency department visit for abdominal pain. He has had no abdominal surgeries, and metastatic workup is otherwise negative. His baseline creatinine is 0.8 milligrams per deciliter, estimated glomerular filtration rate greater than 60 milliliters per minute per 1.73 meters squared. He asks about the likelihood of malignancy and whether this mass should be biopsied. It is important to recognize the role of renal mass biopsy in the diagnosis and management of localized renal masses. The key principle to consider when counseling patients regarding renal mass biopsy is whether the biopsy result will influence management of the patient. While there are scenarios in which renal mass biopsy can aid in diagnosis and guide options for management, there are also many situations in which renal mass biopsy is not necessary and/or may not be diagnostic. Previous meta-analyses have reported that core renal mass biopsy is highly sensitive, 97.5%, and specific, 96.2%, but is also associated with a 14.1% non-diagnostic rate. Although the rate of reported complications is generally quite low, the procedure is not entirely without risk and has the potential to result in a delay of time to treatment. When complications are noted, they may include significant bleeding, that is, hematoma, hemorrhage, or clinically significant gross hematuria, estimated to occur in 1% to 2%, pain, 1%, or pneumothorax, 1%. The risk of bleeding may be mitigated by holding therapeutic anticoagulation prior to renal mass biopsy, and in most scenarios can be managed with conservative measures. In addition, attention should be paid to tumor location when renal mass biopsy is considered. The risk of pneumothorax is higher in upper pole tumors, although there are positioning strategies that may be employed by the proceduralist to decrease this risk. Anterior or medial tumors may be harder to access, in part due to their proximity to surrounding structures, making communication with the proceduralist performing the biopsy important prior to referral. Similar to the previous version of the guidelines, the 2021 update focuses on appropriate patient selection and decision-making based on whether the biopsy outcome is expected to alter the management strategy. According to the guideline, clinicians should consider renal mass biopsy when the mass is suspected to be metastatic, hematologic, inflammatory, or infectious. As a result, other than a primary renal malignancy in these situations may significantly influence management strategy. Conversely, clinicians generally should avoid renal mass biopsy when the patient is young, otherwise healthy, and in whom a negative or non-diagnostic result would not influence management, or in elderly or frail patients who would most likely be counseled toward conservative management regardless of renal mass biopsy result. In the setting in which a renal mass biopsy is indicated, core biopsies should be obtained rather than fine needle aspiration. Analyses have reported inferior diagnostic ability of fine needle aspiration compared to the excellent diagnostic ability with core biopsy, as reported above. The guideline advises that 2 to 3 cores should be obtained with a 16 to 18 gauge needle, with choice of CT or ultrasound guidance at the discretion of the proceduralist. Section 3. Nephron sparing versus radical nephrectomy. Patient Scenario 3. A 67-year-old male presents to you as a referral for a 4.1 centimeter left upper pole renal mass. The mass enhances on multiphase cross-sectional imaging and is partially exophytic, about 50%, appears to abut the upper pole collecting system, and is located on the anterior portion of the kidney. He has a past medical history of diabetes mellitus, hypertension, hyperlipidemia, a baseline creatinine of 1.6 milligrams per deciliter, estimated glomerular filtration rate 43 milliliters per minute per 1.73 meters squared, and has never had abdominal surgery. You counsel him on options for management and ultimately elect to proceed with partial nephrectomy. Decisions regarding the feasibility and appropriateness of partial nephrectomy versus radical nephrectomy for localized renal masses can be complex and challenging. These depend greatly on the individual patient characteristics, as well as the experience level and favored approach of the individual surgeon. The AUA guidelines regarding partial nephrectomy versus radical nephrectomy have attempted to provide guidance as to important considerations in making these complex decisions, although there continue to be patients who do not fit into these defined scenarios. A nephron-sparing approach, that is, partial nephrectomy, is preferred in a large subset of patients. Renal masses classified as CT1A, for which surgery is planned, should be managed with partial nephrectomy. Analyses have described similar oncologic outcomes compared to radical nephrectomy when patients are appropriately selected and have shown good functional outcomes. Partial nephrectomy is also preferred in patients with a solitary functional kidney, bilateral masses, known familial renal syndromes, pre-existing chronic kidney disease, or competing comorbidities such as diabetes, recurrent urolithiasis, or morbid obesity. On the contrary, radical nephrectomy is preferred in patients with large tumor size that is not amenable to partial nephrectomy, or if all of the following criteria are present. 1. High tumor complexity. 2. No pre-existing chronic kidney disease or proteinuria. And 3. Normal contralateral kidney and an expected postoperative estimated glomerular filtration rate greater than or equal to 45 milliliters per minute per 1.73 meters squared. In identifying tumors which would be considered high complexity, some clinicians may find the renal for radius, exophytic endophytic, nearness of tumor to collecting system, anterior posterior, location relative to polar line, nephrometry score to be a useful tool. Developed by Kudakov and Uzo in 2009, It provides a scoring system to grade the characteristics of renal masses, focusing on components such as diameter, exo or endophytic component, location within the kidney, and proximity to the collecting system. The recommendation to preference radical nephrectomy over partial nephrectomy in the case of high-complexity tumors arises from reviews suggesting inconsequential effects of radical nephrectomy in patients with a healthy contralateral kidney at 10-year follow-up. In addition, there are increased perioperative risks with partial nephrectomy compared to radical nephrectomy, including increased blood loss, longer operative times, urine leak, pseudoaneurysm or arteriovenous fistulae, longer hospital stay, and increased mortality. These factors must be considered during preoperative counseling. The major update within this section of the guideline is the emphasis on preferencing partial nephrectomy in the majority of situations. Due to concerns of overutilization of radical nephrectomy, the updated guideline recommends consideration of partial nephrectomy when feasible. Notably, the guidelines do not absolutely proscribe an open surgical approach, though it is recommended that when technically feasible, a robotic or minimally invasive approach should be considered. Section 4. Updates regarding recommendations on thermal ablation. Patient Scenario 4. A 77-year-old man presents to your clinic with a 2.8 centimeter right renal mass noted on ultrasound obtained for workup of chronic kidney disease. He has a past medical history notable for coronary artery disease, previous cardiac stents, atrial fibrillation on apixaban, diabetes mellitus, hypertension, and his previous abdominal surgeries include an umbilical hernia repair with mesh and an open appendectomy. His baseline creatinine is 1.4 milligrams per deciliter, estimated glomerular filtration rate 49 milliliters per minute per 1.73 meters squared. You obtain multi-phase cross-sectional abdominal imaging, which demonstrates the mass is located on the posterior aspect of the right kidney in the mid-pole with a greater than 50% exophytic component. Ultimately, he elects to proceed with percutaneous cryoablation with concomitant renal mass biopsy for management. Thermal ablation is a very reasonable alternative to surgical intervention for localized renal masses in select circumstances. Previous meta-analyses have demonstrated similar metastasis-free survival rates between partial nephrectomy and thermal ablation, and lower morbidity with thermal ablation has been reported. Disease persistence or recurrence has been cited as a concern with thermal ablation compared to partial nephrectomy. However, in these situations, many patients are candidates for salvage therapies, including repeat thermal ablation. There are specific tumor characteristics which make patients better candidates for thermal ablation. In general, these include masses which are more exophytic in nature and generally less than 3 centimeters in size. Posteriorly located masses are generally more amenable to a percutaneous approach, and decreased skin-to-mass distance is conducive. Reviews have suggested a safety margin of 1 to 2 centimeters between the edge of the lesion and surrounding important structures, including the collecting system, ureter, and adjacent organs, that is, colon, small bowel. Depending on the experience level of the radiologist, techniques that can be considered to help optimize location of the masses for a percutaneous approach include retrograde pyeloperfusion and hydrodissection. In cases with increasing mass complexity, location, or size, we recommend that these be discussed one-on-one with the treating interventionist to determine their suitability. Notably, the guideline strongly supports a percutaneous approach to thermal ablation over laparoscopic or other minimally invasive approaches. There was insufficient evidence to support any one form of ablation over another, and the panel felt that both radiofrequency ablation and cryoablation were acceptable technologies. Notably, microwave ablation was felt to still be understudied, as were other ablative technologies such as radiation therapy and other innovative tissue ablative technologies. Complication rates with thermal ablation have been reported to be relatively rare and similar across thermal modalities. These include bleeding or hemorrhage, the most frequently reported, collecting system or ureteral injury, thermal injury to bowel, and nerve injury. In general, we recommend that thermal ablation be reserved for more elderly or frail patients with significant comorbidities who would receive greater benefit from a procedure with lower morbidity, with masses less than 3 centimeters that are located in a favorable location for percutaneous management. When considering thermal ablation, the guidelines emphasize that patients should be counseled about an increased likelihood of tumor persistence or local recurrence. Recurrence in this situation can often be managed with repeat ablation, although a small subset of patients may not be candidates for repeat ablation and may go on to require surgical intervention. Section 5. Active Surveillance. Patient Scenario 5. A 74-year-old woman with a history of hypothyroidism, diabetes mellitus, and arthritis presents to your clinic with a 2.2 centimeter Bosniak 4 upper pole right renal cyst. On your review of her multi-phase cross-sectional CT scan, you notice an enhancing 1.4 centimeter soft tissue component. This lesion has not been seen on previous films. Her baseline creatinine is 0.7 milligrams per deciliter, estimated glomerular filtration rate greater than 60 milliliters per minute per 1.73 meters squared. You discuss options for management with her, and she elects renal mass biopsy with pathology revealing type 1 papillary renal cell carcinoma. She elects active surveillance of the lesion, and you plan to see her back in 6 months with repeat cross-sectional imaging. Active surveillance has been a widely utilized option for the management of localized small renal masses for some time, and there is a growing body of evidence to support this strategy. In the field, it is widely understood that the metastatic potential of renal masses less than 2 centimeters is extremely low in most patients, and cancer-specific and metastasis-free survival have been reported to be as high as 98% to 100% in the short to medium term. Previous series have described nearly negligible metastatic potential of masses less than 3 centimeters, but when further size stratified, the risk of metastasis of masses less than 2 centimeters is virtually zero. Active surveillance continues to be a safe and reasonable option for patients, especially when compliant with follow-up and periodic imaging as detailed in the guidelines. If previous imaging is not available, a reasonable active surveillance schedule would be to begin with imaging every 6 months and extend or tailor intervals based on individual growth kinetics. Clinicians should begin with cross-sectional imaging, CT or MRI, and may incorporate ultrasound into the surveillance strategy as dictated by patient factors and stability of the lesion in question. The most updated version of the AUA guideline also places an emphasis on consideration of active surveillance for predominantly cystic lesions. Bosniak 3 to 4 lesions fall into the category of masses which should warrant consideration for intervention given their increased malignancy risk, but in this section, importance is placed on evaluation of the solid versus cystic component. More recent series have shown that active surveillance of Bosniak 2F to 4 lesions over a median of 6 years showed excellent overall and disease-specific survival. This suggests that urologists should carefully examine imaging and use factors such as the size of the solid component rather than total size of these mixed solid and cystic lesions to help guide the management strategy. If the risk-benefit analysis is equivocal, The guideline suggests performing a renal mass biopsy in those lesions with solid components to help guide decision-making. Once a patient elects active surveillance, it is important to repeat imaging within 6 months from the initial diagnosis to determine stability and appropriateness for continued active surveillance. At any point, there is the potential to elect intervention should the clinical situation change. While the guideline does not advise an absolute threshold in terms of growth kinetics that would dictate change in management to intervention, previous series have used a growth rate of greater than 0.5 centimeters per year as a cutoff. While the guidelines do not specifically address the management of Bosniak 2F lesions, previous reviews have suggested follow-up every 6 months for 2 years, and then annual surveillance beyond this period as a possible surveillance schedule. Section 6. Follow-up. Patient Scenario 6. A 64-year-old male presents to your clinic with a 3.2 centimeter partially exophytic right renal mass that was not present on remote imaging from 7 years prior. His creatinine is 1.1 milligrams per deciliter, estimated glomerular filtration rate greater than 60 milliliters per minute per 1.73 meters squared. After the appropriate counseling and workup, he ultimately undergoes a robot-assisted partial nephrectomy, with pathology revealing clear cell renal cell carcinoma, grade 3, PT1A with negative margins. His postoperative course is uncomplicated. You assign him to the intermediate risk category based on this pathology and plan to see him back 6 months after surgery with an abdominal MRI with contrast and a chest X-ray. The most notable addition to the 2021 guidelines includes a section with recommendations for follow-up, an area that did not exist within the previous versions but was incorporated from a prior separate guideline on renal cell carcinoma follow-up that was subsequently retired. In addition, it provides guidance on a risk stratification system for patients treated with surgery, with imaging sequences and timing based on these risk groups. The first subsection of the follow-up portion of the guideline covers general principles related to follow-up. It emphasizes the importance of routine laboratory testing, imaging, and urinalysis in these patients, and highlights the role of an informed patient discussion regarding stage, grade, and histology so that patients may be equipped to be active participants in their follow-up. It also highlights the importance of routine history and physical and attention to new symptomatology. The guideline recommends against routine brain, bone, and positron emission tomography, but acknowledges that some of these modalities may be useful in the setting of the onset of new symptoms. When metastatic disease is suspected, multidisciplinary services should be consulted and involved in the patient's care. A key point of this addition to the guidelines is the recommendation to risk stratify patients into groups based on their pathology following extirpative or ablative treatment. There are several nuances to consider within this algorithm as well. If the final macroscopic margin is positive for cancer, the recommendation is to consider the risk category as at least 1 level higher, and these patients should be followed more closely than patients with negative margins. Another key distinction is that following thermal ablation, patients should be followed in accordance with the recommendations for the intermediate risk category. A recommended schedule for follow-up based on the assigned risk category is also suggested. Both abdominal imaging and chest imaging should occur in accordance with this schedule. Key points to consider in this recommendation include the importance of early follow-up with abdominal cross-sectional imaging, with the preference for physician discretion in terms of imaging modality and schedule after the initial follow-up period, especially in the low-risk or intermediate-risk group. The guidelines suggest that for these groups, after 2 years, ultrasound may be utilized in an alternating schedule with cross-sectional imaging if desired. Chest imaging should also occur in accordance with this schedule, with preference for cross-sectional imaging in the high-risk and very high-risk groups. In contrast to previous guidelines suggesting that surveillance can be discontinued after 3 to 5 years, the authors point out that some studies have suggested up to 30% of recurrences can occur beyond 5 years after surgery, which should lend consideration to longer-term follow-up, especially in younger or higher-risk patients. A point not made in the guideline, but that may be incorporated in future updates, relates to the role of adjuvant therapy. Given recent data demonstrating that adjuvant pembrolizumab can improve recurrence-free survival for patients with high-risk disease, defined in the Keynote 564 study as patients either with stage PT2 with grade 4 or sarcomatoid differentiation, stage PT3 or higher, those with regional lymph node metastasis, or stage M1 with no evidence of disease, patients with such features should be counseled on the option to receive adjuvant therapy. Conclusions. Important changes to the 2021 small renal mass guidelines have been highlighted above so that clinicians may appreciate these updates and nuances. Importantly, the expansion of a section with recommendations for follow-up will help standardize and improve care for patients after initial management. Did you know? Genetic referrals should be provided for patients less than or equal to 46 years of age with a diagnosed renal malignancy, as well as those with personal, familial, or pathologic risk factors. Renal mass biopsy should be considered when the result will influence patient management and should involve obtaining core biopsy samples rather than fine needle aspiration. Partial nephrectomy should generally be favored over radical nephrectomy in appropriately selected patients when technically feasible. Active surveillance is a safe and reasonable management strategy for the majority of patients with renal masses less than 2 centimeters and in those with predominantly cystic lesions. A section on patient follow-up after renal mass surgery has been added to the guideline and includes a risk stratification system and proposed surveillance schedule.
If you enjoyed this episode and would like to learn more information about the AUA Update Series, including how to subscribe, please visit the AUA University at auanet.org/university.